morning. I am Suzanne Lawson with Constellation Consulting, and we are pleased to present the 2020 New Mexico Summit on Health Equity Virtual Series. This series is funded by the New Mexico Department of Health Tobacco Use Prevention and Control Program and will take place each Thursday through June 25th. For more information about the summit and our upcoming presentations, please visit our website at nmhealthequity.org. While originally intended to be an in-person summit to address health equity within the live, work, play model, the 2020 New Mexico Summit on Health Equity became a virtual series this year due to COVID-19. We appreciate the efforts of everyone involved in transitioning this event online, including our presenters, the Department of Health, Alliance Audiovisual, and the members of our Constellation Consulting team. For Zoom security reasons, for today's session, we are utilizing the Zoom webinar feature, and attendees' webcams and microphones have been disabled. If you would like to introduce yourself and engage with other attendees today, please feel free to do so in the chat feature. If you have a question for today's presenter, please use the Q&A function, and we will address as many questions as time allows. Any materials provided by today's presenter will be posted on our website. You can also access a recording of today's presentation along with recordings of our past sessions at nmhealthequity.org. Following today's session, you will receive an email with a link to an online evaluation. We encourage everyone to take the evaluation. If you would also like, if you would also like to receive community health worker or social worker CEUs or continuing medical education units, you must complete the evaluation. CEU certificates will be emailed out within 30 days of completion of the evaluation. This year, we are excited to offer you all an additional way to engage and connect with others participating in this year's Summit on Health Equity virtual series. As an illustration of our continued growth as a community, we invite you to participate in our virtual mosaic. This mosaic will be built over the next several weeks and will be made up of photos you send in to us. You can send in one photo or several. They can be of you or you with those you may be with during this time, or even images that you find that are inspired by this week's presentation. To be a part of this, please send your pictures and images via email to info@constellationnm.com with the subject Mosaic. The Mosaic is currently live at nmhealthequity.org, and we will continue adding photos each week. And finally, before we begin today, on behalf of Constellation Consulting, racism has no place in our communities. We are New Mexico, and we were built strong by the diverse people of our communities. There are a variety of organizations supporting health equity throughout our state. We have listed just a few here and encourage each of you to seek out, learn more, become involved with, and support organizations who are building a better world for us all. Today, we are excited to host Dr. Melissa Riley as our presenter for this fourth session in our Summit on Health Equity virtual series. Melissa Riley is the Executive Director at Indigenous Women Rising and is also a consultant to several national, state, and tribal agencies, as well as public and private organizations. She has managed federal projects within the Department of Justice, Office for Victims of Crimes, my apologies, such as National Counseling and Faith-Based Services for Crime Victims in Indian Country Training and Technical Assistance Grant, and the Children's Justice Act Partnership in Indian Country Training and Technical Assistance Grant. Dr. Riley co-authored a national faith-based curriculum, produced training and technical assistance videos, and published training guides for 2 of these projects. Additionally, she has developed curricula for the New Mexico Department of Health, Office of Community Health Workers, Gallup Indian Health Services, University of Texas at Arlington, and other organizations. You can read her complete bio on our website at nmhealthequity.org. Please welcome Dr. Melissa Riley.
All right, well, thank you for that very detailed introduction, and I'm so happy to be here with all of you virtually. So as mentioned, I'm Melissa, and Rachel Lorenzo, who was scheduled to be with us this morning, unfortunately is not able to. We represent an organization called Indigenous Women Rising, and because of the various components of that organization, we have become accustomed to talking about um, various health issues that affect Indian country, not just here in the state of New Mexico, but beyond. So I'd like to share some information with you today, and I hope you enjoy this presentation. So with that being said, I'm going to go ahead and start here. If I can. Okay. Okay, so many of you probably saw the workshop description and saw the determinants of health, and I know that's been a very rich and healthy discussion amongst many providers here in the state of New Mexico. But along with these conversations, I want to provide a little bit more detail and understanding from a Native person's perspective.
And Dr. Riley, I am so sorry to interrupt you, but we are not seeing your screen yet.
No. Okay, everybody, I am just still learning here. And okay, can you?
Okay, there we go.
All right.
Thanks so much.
Yay. Thank you. Sorry about that. So I just wanted to provide my own perspective based on my education, but more so my experience and training about this topic. There are several issues that affect Native communities, even urban Indian communities. But when we talk about social determinants of health, it's a little more, there's a little bit more information that goes into this that I think oftentimes my colleagues and I need to have more discussions about to make us more aware of what the social determinants of health actually are for our Native population. So in this overview that I'm going to provide to you this morning as you go along, I'm going to be talking about at least the primary issues that I would categorize as determinants of health for our Native population. Also sharing with you some incarceration rates, but I also include in this discussion the opportunities for civic engagement that exist, and some that maybe we need to look at a little more closely to make this discussion as we move beyond our virtual presentation today, but actually implementing in the work that we do with Native communities. Because overall, we want to be able to bring people together and help people on a healing journey. I am trying to. So Suzanne. Okay, so I just did that brief overview here, and there are some areas or topics that I'll be covering, which again, civic engagement and participation, institutional racism, incarceration, and really the need for social cohesion, and what does that look like? So here are our workshop objectives, and I hope by the end of this presentation you can reflect on these once more, and hopefully I can help achieve them through the discussions that I'll be offering today. I'm going to be stopping periodically after certain topics and asking Suzanne if there are any questions in the chat box that I might be able to respond to briefly, and then we'll move on to the next discussion. So this World Health Organization describes social determinants of health as the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. And I want to take hold of that definition in regards to the systems or the environments that we are born into. There are so many bases of, you know, what we do and who we are as individuals, as Native Americans, You know, we're born into systems, but what are the things that occur throughout our lifespan that creates change, whether it's good change or whether it's not so good? And I'm going to talk and bring into our conversation today one of the theorists that I worked in under their thought process as I was pursuing my master's and doctorate degree, which was Bobby Harrow. And she provided a really nice and fascinating way to look at how we as individuals are shaped, how we think, the things that we do, and the opportunities that we have throughout our life that give us an even greater opportunity to become liberated, and how this impacts the social determinants of health as we see it in our tribal communities. So I'll be going over that a little bit more as we move on here. So some considerations for action and how we approach social determinants of health as helping professionals is looking at our environment in three ways. There is an inheritance of historical events and actions that brought us to this place of where we're at right now. And there are things that we need to truly own and acknowledge that occur within our communities, such as fault, blame, and inaction. It's kind of like, you know, you complain about how, I'm going to use this example, how very low quality healthcare we might receive through Indian Health Services, and we may be blame providers for not providing us the care that we think we deserve. However, what good is it to blame and find fault whenever we don't do anything to help us? But in more perspective, what do we do to help empower the people that we work with and the people that we live with in our community to get the tools they need to create action, to create positive action, and even some uncomfortableness? And also, we need to do a lot better job. And I think this is just a growing pain, even for myself as a provider, is we need to constantly be looking at our approach and how we understand and also interpret the needs of our community in order for us to be effective and to respond to these determinants of health, because they do affect us in so many different ways, from a policy level, economic level, housing level, and so forth, even our social services programs, to name a few. So here is that graph or that mention at the beginning of the presentation regarding the cycle of socialization. And why this really sticks to me as a Native woman is that being born on the Mescalero Apache Reservation, Indian Health Service, to a 16-year-old mother and a 17-year-old father, I didn't have a choice. And I don't think I would want a choice even after what I've gone through in my whole life. But how I was born into this system, into this community with these two parents, really shaped my view of the world. And it was also influenced how I continued to move about in the different stages and the different institutions that I became familiar with. Catholic Church, I'm a Catholic. I went to tribally controlled schools. All of these things, they really helped shape who I was and how I saw my environment. This is good, but it also can be not so good when we think about the negative things that happen in our life that cause us to feel in that centerpiece of the diagram, fear, confusion, feeling insecure, sometimes perpetuating ignorance or feeling ignorant, unknowing of certain systems and things that really would help us become stronger and feel empowered to make changes that we need to in our own life. So just thinking about that perspective and thinking about all the things that we go through in our life, how do we really process that? And how do we process it in such a way that it becomes the gain of the people that we work with and live with in our communities? It's so important to do that self-evaluation and understand where we've been and where we're going. So there's the paradox of health that I want to start off with, in that we have this idea of health equity and what that means, whether it's good and equal access to quality healthcare systems, mental health, help for, our dietary needs. We have this really, I think, oftentimes vision that is so, it's something that I want to grasp onto. But then we have a different reality, or a reality of systems that are not working for us. So when our values related to healthcare are not in an alignment with what our reality is, this creates a lot of problems, and it often creates a lot of feeling of no growth, especially with the individuals that we work with, or I work with, I should speak to. It's like, as a social worker or as an educator, I can tell people, well, I think maybe if you took a self-help class or a parenting class, this would really help you gain some strong parenting skills and how to handle a teenager. Well, that's ideal. But what is that individual's reality, and the challenges that exist in their life that prevents them from getting to that ideal place that I'm telling them to be at? So just an example of, where I'm going with that paradox of health. And it's something that I often see at so many different trainings and seminars. Okay, we want health equity. This is, what we don't have, or maybe we're just beginning to taste a little bit of that equity. But what is the reality of the systems in general? So when we talk about paradigm shifts, it's really about looking at the true disparities that exist within our communities and within the state and the country. And that paradigm shift is going to change through liberating events, through things that are happening. And whether we're a part of that push for change, or we're a part of the group that is forcing something positive to happen, that's how we're going to shift things and create that equity that we so much need. So I don't know who is all on the call today, but if you're associated or you're well aware of Indian Health Services, we are probably the most underfunded health service system for our Native people in the entire country. We were expected to provide physical, mental health, social work, public health nursing, and a slew of other services, but on a budget that really is probably only able to serve a very small handful. And the system in itself tends to be more reactive. We tend, through Indian Health Service budgets, to appropriate more money in emergency-based services as opposed to preventive services. So there's a huge disparity in how we're looking at it, I think, even from our Indian Health Services perspective. But among non-elderly adults, a lot of our Native people are more likely than the overall population to have poor health. If you look at a lot of research and studies with those of you that are in the medical field, we suffer from a lot of chronic health problems, illnesses, diabetes, um, kidney problems, and those types of things. So with all of these health problems that plague us, including mental health issues, whether it's post-traumatic stress disorder or bipolar or trauma of some type, we don't have the resources to adequately respond to that. And that's really an important piece, because all of you know, we need to feel good physically in order for us to be healthy and think in a healthy way to move things forward for ourselves, for our families, and for our community. Common disparities amongst our Native communities, Native populations, urban Indian, is health, as I just mentioned, employment, and poverty. There are really not a huge number of employment opportunities. And when you think about what the current environment is right now with the COVID-19, this pandemic, it's really, really put us back decades, I would say, as far as economic growth than what we were up until March. So there are a lot of things that are happening, and I think that those disparities are becoming increasingly apparent. And the more that we have these disparities, the more issues that we're going to have as far as social problems, community health issues, whether it's violence, health problems stemming from poor diet, not having adequate resources, such as library services, which are truly important, school services, those types of things. All of those institutions or programs that exist in tribal communities right now are really not being, there's a limited amount of support than what we had back in March or prior to March to help our schools grow, our communities grow, gainful employment, and so forth. So making the economic connection, as what I'm trying to do right here, is that we really need to look at, or something that I talk about with colleagues and tribal leadership, is that there is a correlation of economy with health disparities. When I mentioned about Indian Health Services earlier, they have a shoestring budget, and they're only responding to or reacting to health problems as opposed to working towards the prevention side. Well, that takes a lot of money, and it takes a lot of resources away from other areas that we could grow from a prevention intervention perspective. So the lack of jobs, and thinking about the poverty rate, those continuous correlations that really need to be addressed and looked at a little bit more in order for us, as helping professionals, to be effective in the communities that we're working with. So, of course, this is an old labor statistics statement here, but that Native Americans have the lowest employment rate of any racial or ethnic group in the United States. Well, right now what we're doing is we're having a virtual presentation and hopefully a discussion later on. And you think about what the virtual requirements are for us to be effective in education, employment, and so forth. But when we don't have the technology that we need to make things happen, to look for a job or obtain a job where we're going to be required to telecommute, then this continues to further set us back. So the discrimination and stress that I wanted to just mention briefly in regards to the social determinants of health is that there is a lot of stress that people feel. It's not just with other minority communities or poor white communities, but with Native Americans, there's already a psychological and physiological effect as a result of discrimination. People's reactions, they get stressed out, they're hypervigilant. It impairs their ability to work effectively or to be a part of a workforce. It affects parenting. It affects decision making on several different levels. So the more that individuals or communities experience discrimination, the more stress that it puts on individuals. And not everybody is able to handle stress. And there's 3 types of stress that I'll talk about here very quickly. And the long-term effects of that discrimination and that stress is withdrawal and avoidant behaviors. And a little bit of what I mentioned in that Bobby Harrow, the cycle of socialization graph that I put up earlier, that's a part of that. The more that we experience negative things and the more that it's ingrained as, it's just a part of life, it's a part of institutional racism, discrimination, sometimes the more accepting of it we are, and it perpetuates younger generations to possibly take that same path of inaction or just feeling like there's just no way to fight it. So we really have to work really hard about moving away from that inaction in order for us to get to that equity level. So other parts of social determinants of health that we need to, this could be a whole full day training in itself, but it's structural violence. And this is created and corresponds with the systemic features of our communities, in which social structures or institution kills people slowly, whether it's physically or mentally, by preventing them from meeting their basic needs. There's some examples here on the slide of the life expectancy for Native Americans is, considerably less than that of the overall general population. And of course, a known fact is tribes have some of the worst health disparities and economic conditions of minorities. So when we think about that structural violence and the systemic racism, institutional racism that prevent us from, accessing healthcare, education, employment, homes, those types of things, that does prevent us from growing, and it does prevent us from being healthy. It prevents us from having, good, possibly good quality running water, gas in our home, and those types of basic necessities that are so important for us to survive. So I want to share this slide, and of course, it's not representative of communities that some of you may have seen or worked in. There are some tribal communities where they're very well kept. They're in small, isolated, or areas where they have good housing. They have paved roads. They've got, yards with trees and running water near them. But the picture on the left has an image of a home in Africa. There's a home in Haiti, Mexico, and then there's an image there from one of our reservations. So kind of that third world country discussion that maybe some or all of you have had in regards to our tribal communities is, we are living in a third world country. with a lot of our reservation systems, including our Alaska Native brothers and sisters. You know, what people see when they go home, if they live in these communities, after a while it's desensitized. You know, you don't feel it anymore. It's just a part of the norm. And, you know, the youth are who we are really depending on to get our generation forward and continue with our language and culture. But when you think about social determinants of health, desensitization, and the environment that we're in, what are some things that we need to do to help create change, to get people to a point of liberation and going from inaction or inactivity to action to make health, whole person health, feasible? So food insecurity is another aspect of this presentation. And many of you, or all of you, know about some of the issues regarding food insecurity and access to quality food, to healthy food. I've done work with organizations up in the Gallup area, the Four Corners area, out in, you know, different reservations where if you're dependent on SNAP benefits, you're dependent on commodities, and you think about the nutritional quality of some of the commodities, and you think about the nutritional quality that is available in a convenience store or a small tribal store, it's really not there. It's very limited. So how do we address food insecurity and correlate that with healthy eating, access to healthy food, and looking at the economic, the lack of the economics that are available to families? So location, location, location is always going to be a part of this food insecurity discussion. And you know, it goes back into what I said earlier about the health paradox. You know, we have this ideal of what healthy foods and access to healthy foods, diets, exercise, and what all of that means. And we know for those of us that have a job in education, that these things are important. And some of us are able to maintain a somewhat of a healthy lifestyle. But when you think about providers that I've worked with before, and they're telling a native person that they need to get their diabetes under control and they need to start doing some more healthy eating, that's not realistic. That's not a realistic conversation for that client or that patient, because their location and the lack of access or resources to actually get and live a healthy lifestyle isn't going to be there for them. And that just perpetuates more stress on them and a feeling that I don't want to go to the health provider or the doctor anymore, or the dietitian, because they're telling me all these things and I can't do it. So, you know, this discussion, especially regarding food insecurity, determinants of health, other determinants, really we need to think about the stress that we cause on our clients and patients in this respect. And again, the income. You know, what do people actually have available to them in the through money, dollars, or SNAP benefits, commodities, and so forth? What do they have that is able to purchase all of those things, the basic necessities? So according to the Native American Partnership Organization, which is out of Arizona, they, through the tribes that they serve here in the United States, have identified that there are 60 reservations in the United States that grapple with food insecurity. I know that there are some grants and some programs that are actually running or they're receiving funds to create gardens and harvest the food from those gardens so that people can learn how to plant, grow, and harvest their own food, their healthy food. And that is wonderful. That is so great. But when you think about here in New Mexico, the Pueblo tribes do not own their own water rights. They, so water can become an issue to making or minimizing the food deserts that we often hear about. So, in food insecurity, it's a reality. It's what happens. It's being identified with organizations and creating or helping them respond to reservations that need food. But when you think about the environmental issues regarding water, land, fracking, gas, and those types of things, and where some of our reservations are located, how do we help people get to a point where they can ideally have their own food and minimize or get rid of food insecurity? And how do we work with tribal governments and other organizations to address this? I'm sure some of you are going to have some questions coming up soon or some thoughts on this. So Suzanne, with that being said, just to check with you, are there any questions or comments?
Currently, there are no questions or comments.
Great. So stress, I mentioned stress earlier. So there's 3 types of stress that exist. And of course, this is taken from information regarding children, child welfare programs such as Joint Forces for Children. So positive stress, normal things, you've got a deadline you got to meet, and you've got a homework assignment, or you got to go pick up the kids or make a medical appointment. Those are some of the positive stresses that we respond to and we get beyond. Then there's the tolerable stress, which is possibly the loss of a loved one, hopefully loss of employment, things that you can bounce back from. But then there's the toxic stress that occurs. And this is related more to trauma that you experience through violence of some type, or something happens in your community that's devastating, such as right now we are experiencing a pandemic, and that is a part of the toxic stress. So understanding the different levels of stress and how we incorporate that into working in addressing the social determinants of health with communities is important. Just briefly, I just want to mention here, we probably have a number of you that are familiar with the Adverse Childhood Experiences, which is ACE. So there's 3 types of abuse, or 3 types of ACEs, which is abuse, physical and emotional. There's neglect, which is also physical and emotional. And then there's also the household dysfunction, violence that is occurring within the home, mental illness, substance abuse, incarceration. And for myself, as working in the field of social work, primarily most of my career, I don't completely agree with all of the different questions that determine, and the scoring that determines whether somebody is high risk or is scoring extremely high for being at risk for behavior. And the reason is because we have a lot of resiliency as a Native population. What works for one population or even one tribal community may not be the same for others. And I know there are a lot of colleagues of mine that disagree, and that's fine. But I think about my own childhood experiences with abuse, neglect, and violence in my home, and mental illness. And there are just certain things that happen in a number of people's lives. And I think it's really dependent on what resources are available to help guide to another path. So just wanted to share that thought, that perspective right there. And I see that we are at 12:10 p.m. right now. So there's some additional information, is of course offered by the Center for Disease Control regarding ACEs. Just some brief statistics: 61% of adults surveyed across 25 states reported that they had experienced at least one type of ACE, which is, it's pretty significant when you think about that percentage. And you think about how adverse childhood experiences affects one's health, physical health. And I guess if you took that inventory with all patients in a hospital or a clinic at one given time, would that truly correlate with the health conditions of our community members? That's just a question that I have. I haven't seen a lot of any research or anything of any study that specifically speaks to that for one given community. And why I bring this up is, for myself as a researcher in collecting data and analyzing that data, I really have to make these correlations in order for me to really get a full picture and understand what my role is in this picture of helping communities or individuals or certain groups of people. There's some other references here regarding children being at greater risk than others, especially in relation to their racial and ethnic background. And also, ACEs are costly. I mentioned the economic correlation earlier in the presentation, and here's another one. The more that we keep communities without resources or proper resources, or we just kind of band-aid problems, it blows up. The problems, social issues blow up. Policies tend to not always address those issues, but it really is has an effect on our pocketbook. Whether you're a taxpayer or whether you're advocating to build a new senior center in your community, but you find that we'll have a higher incarceration rate than what we did 2 years ago, so we need to appropriate money towards criminal justice versus a senior center. Those are just some examples of what the costliness sometimes looks like in our communities. Youth incarceration is something that I don't think I mean, it's talked about, but it's not talked about in such a way that we really are truly understanding the problem. If you see on your screen, you have all of these percentages, and our Native youth are incarcerated at a higher rate than white youth. It's unbelievable. But here's what I want to share about the youth incarceration rate. We in tribal communities adhere to a different law than non-tribal people living off a reservation, living in an urban community. Tribes, for the most part, set their own juvenile codes, their law and order codes. So our youth are judged in a different fashion than non-native youth. And this is the big difference here, even with our overall incarceration rates and looking at our data regarding Native and Alaska Native people, is that when we commit offenses on the reservation, depending on, of course, where you live, there are some tribal communities that are bound by state law. There are tribal communities, such as here in New Mexico, where we have federal law, which is the Bureau of Indian Affairs, the Federal Bureau of Investigation. We have federal law versus state law and tribal law. So if we commit a crime and it's similar to what somebody committed, a non-native committed in Albuquerque, and we commit this crime at Laguna, well, the charges and the incarceration rate, or who's going to take jurisdiction, is going to be a lot different. So when I look at these data points and these statistics, those are things that really come to mind that I would want people to understand about incarceration of Native people, is that we have different law and order codes, unless it's a federal law, such as domestic violence, homicide, embezzlement, or any of those federal crimes. And of course, you know, the federal code is across the board. But for these other situations that don't reach the U.S. Attorney's Office, you know, our incarceration rates are dependent on what the local government has adopted through tribal council or corporations or what have you. So I did talk about this, so I'm going to go on to our next one, which is civic engagement. And why I have decided to put this as a part of a discussion for social determinants of health is because it's important to know that that as we move forward and we look at the positives and try to approach things from a strength-based approach, we need to look at what our community can do. And civic engagement is, it's possible. It should always happen. But what does it look like? What does that look like to us from a tribal perspective or from a Native perspective? And it's, you know, it comes in various forms, whether it's volunteerism, whether it's, you know, putting together work groups to solve a problem, addressing homelessness in a community, in an urban community, writing letters to officials, attending tribal council meetings, village meetings, or what have you. Civic engagement has many different forms. It comes in many different forms, but it should always be a part of a discussion when we talk about what are we going to do in addressing the determinants of health as it relates to Indian country. Voting, we are in a year of election, and I think it is appropriate to just give a little bit of background regarding voting for our Native people. So the Indian Citizenship Act of 1924 excluded us from the democratic process. And in 1948, Native Americans in New Mexico and Arizona successfully litigated their right to vote. And I always stop and think about this because my grandfather was in the Korean War, and he, my great-grandfather was in wars stemming from the Geronimo days. And his name was Francisco Big Mouth. And he died when he was 116 years old out in Mescalero. And why I wanted to bring this is he still had a flag that had 14 stars on it in his possession before he died. And he always said, You know, it's really interesting that the US government calls us to go and help fight wars overseas, but yet we can't go and vote. We can't have a voice. Very wise words for an elder. And I always thought about that, because even after he had the right to vote, before he passed away in the late 1960s, you know, he never, you know, took up the chance to go cast a ballot for anybody. But civic engagement from a voting perspective, it's changed in the sense that we have the right to vote. But when we think about what's happening now with either gerrymandering or mail-in ballots or voting in person and those types of things, this is where we really need to work on getting out the information for people to feel comfortable about voting and having them understand what their voice means during this democratic process that we go through. So this is a very important part of civic engagement. I come from a tribe where we are able to vote. We are able to campaign and do all kinds of stuff. We go through primaries at Mescalero, but we do have some communities here in New Mexico that is not the case, that leadership is selected based on clan or you know, other traditional groups. So voting is important, local, national level, but it's important to understand the history of voting so that we can have more enriching conversations with youth and those that we're trying to help get to the poll here in the country. We have a lot of youth engagement opportunities through education, prevention. We have a lot of federal, state, local grants or funding sources that help us with this. But this is just my experience, but for the most part, a lot of these programs are targeted towards at-risk youth. And I think we really need to have all youth involved so that we can get diverse perspectives and experiences that help guide good policy development, program development, and create a more unified approach in how we create programs for those people that they are intended to serve. So these are just a list here of what I've seen as available for our youth, but we tend to promote it more with our at-risk population than we do for an overall population. And I think that when we continue to work in this path, it tends to stigmatize youth in a sense that because there's something wrong that they're being given these programs to work in, as opposed to having them work with their peers in an equal setting and they're on an equal playing field to motivate them and help them work for things that help change. So what can we do about these inequities that I've talked about? And this presentation does not encompass all of them, but a lot of what I've got to walk the talk as an individual helping professional. And a few things I can say is that what we can do is be an ally to everyone. We listen. We need to listen. I know I'm still growing in that area. Do a lot of self-reflection, accept feedback, experiential reality, and cultural competence, moving towards cultural humility. I think that when we're able to take care of our own house, which means our own being and our own setting, that we become more effective and we're more genuine in the work that we do. And community and individuals in those communities can see that. So I think these are things that are important for us to have in our toolkit. So earlier I showed an image of the cycle of socialization, our beginnings as individuals, but this is the cycle of liberation, which is the part that we enter in when we've had that life-changing event, that aha moment that gets us to wake up and think about things that we need to do to help us build a strong core within ourselves that makes us confident as people, as community members, and going out and working towards change in our community and addressing issues within our communities, health, economic issues, the poverty issues, all of those things. So this is really important. And I always ask students or those that I teach, as I've taught it at the community college level, at a school of social work, is think about yourself. Where are you at in either one of these cycles? Are you still growing and you're still in the socialization process? Or are you in the liberation process? And if so, what happened to give you that aha moment? And what is your goal and what are you aiming for in creating change? So Suzanne, I don't know if anyone has any questions.
We do have a couple of questions thus far. The first one goes back to an earlier part of your presentation. This person said, who owns the water rights if not the tribes?
Wow, thank you for that question. And I'm going to refer to, so we have a situation. I live at Laguna, although I'm from Mescalero. I'm married out in Laguna. So the Pueblo of Laguna and the Pueblo of Acoma are in litigation with the land grant communities because the water flows from like the Milan, San Rafael, all those areas, and that water is said to be, they claim they own it. The Pueblos are asking for ownership of that water as well. And I want to raise this because it's a good question and I appreciate it. And some of you may know me, and I really was shocked at the lack of information that a lot of our Native people had here in New Mexico, that we don't have water rights, and that whenever we were out trying to support our natives out when DAPL was occurring, one thing I kept thinking of, gosh, they're darn lucky to own some water because we don't own it here in this part. So yeah, so it's up to us to make nice with our land grant communities and county commissioners and so forth to help us, because this has been a long litigation process for some of our tribes.
Okay, thank you. T says, working with clients in the past through providing diabetes education, many would mention they were unable to eat healthy due to low income and living status, which made it difficult for them to manage their pre-diabetes and diabetes properly. What would you suggest for this instance as in addressing food insecurity?
Thank you for that. Thank you for that question. My suggestion has been, or is, because it's just something that I've done personally in working from a social work perspective, is that whenever families have been given a doctor's order or an order from a dietitian that they need to start cutting back on carbs or increasing more green leafy vegetables or what have you into their diet, something that I've done is sit down with clients and ask them, what resources they have that purchases food. If they're in a household where they have a number of people who are receiving SNAP benefits, and one person who is not the patient is responsible for going out and getting the food or buying the food, then I try to expand that conversation with permission of the patient or client to that family member. Because what I try to do is inventory what resources do they have to purchase food or acquire food, who purchases the food for them if they're not able to, assess where the resources are within the community, and if it's just one tribal store or one store in Shiprock or whatever, then I look at, try to make the effort to go up there and look at that location to see what they have and do some price assessment for them, and then look at whatever recipes are provided by the dietitian or the doctor and see how we can work from that end to make it possible where they can cut some carbs or add in those vegetables or what have you into their diet. And it's all really an individual, it's an extensive individual case by case basis that I've been able to work through, that I feel has been successful. Because I think whenever people feel like you're able to sit down and talk with them about these different issues related to their health, they become a little more independent in making healthy food choices and being able to say, you know what, you guys are ordering pizza or you guys are having pasta tonight, but I think tonight I'm just going to have this salad. Because at times, especially for our older folk, they enjoy that companionship and having a dinner together or sitting all in the living room watching TV together. But, being able to empower them to make those healthy choices based on their current resources has worked for me in what I've done.
Thank you. And T, who asked that question, said thank you as well. We have a question from Melissa Ontiveros, or it's actually more of a comment. She says, I have worked in youth programs for many years. I think it's important that we identify all youth to be at risk. It's not only youth who face barriers or have been marginalized, it's any youth at any time that they can be considered at risk.
Okay, well, I appreciate that comment. And I think that if there are, just my perspective, but I appreciate what you're saying, there are certain communities that are at a higher risk. So yeah, you would look at the students or the youth at all being at risk for behaviors. The kind of flip side of it, though, is that sometimes you really got to look at the at-risk indicators that you've established. And I think that we need to be responsible at establishing those at-risk indicators for our own communities. Because when we tend to use indicators from a national level, state, federal, our situation, one community isn't going to be the same in another community as far as resources. Some communities have health centers, they have after school programs, they have a wealth of resources. And I say wealth not in a financial way, but they have more resources than other communities are. So their at-risk indicators versus a community that has limited resources, their indicators are going to look a little differently. But I would agree that there are some communities where you would look at all of the youth as being at risk.
Okay, thank you for that. We also have a comment from Maureen, who says this presentation has been terrific. She says, this is excellent insight. Thank you. This speaks to so much that our coalition is trying to learn, share with the community in discussing health equities and historical trauma. I hope this will be available to share as a link later. She's learned a lot, and this is one of the best webinars she has attended in years.
Oh, thank you.
And I will just add that a recording of this session will be posted at nmhealthequity.org. Probably by tomorrow, no later than Monday, I think for sure. And then if Dr. Riley would like to share her slides, then I'm happy to post those as well.
Yes, of course. Suzanne, I'll be sending you the PDF of the presentation, but you know, anyone who is interested or would like to use it, you know, Rachel and I are all about sharing the resources and understanding not everything in here may be something everybody is in agreement with, but you know, please use it as a resource if necessary.
Good, thank you. We do have a couple of more comments and questions coming in. First, Melissa, who had the comment about at-risk youth, said, thank you very much, that she enjoyed your presentation. We also have a couple of questions from Matthew, who says, many downstream approaches are sustained through established payment systems. Do you have any ideas about shifting thinking to upstream approaches and maybe creating payment systems that sustain them?
Payment systems, are you talking about billing?
Matthew, I'll let you respond. He says yes.
Okay. Payment systems, and you know, that's a good question, Matthew, and one that I was not quite prepared for. If we're talking about billing and we're talking about revenue as a means for growing programs or enhancing or building capacity with programs, I myself am very careful about taking on models from other communities. And the reason is that we really need to do a better job within our tribal communities about conducting assessments and creating clear definitions of what problems actually are. And I'll give you an example. Several years ago, we were very engaged as a nation, as Indian country, with cyberbullying. And I would go to Department of Justice trainings and, you know, be out there and listening to different people, and everybody was saying, wow, you know, we really need a code for cyberbullying. We need to get this going for cyberbullying. And my question to a lot of people were, how do you define that in your community when you don't have the technological capabilities or Wi-Fi connectivity as compared to a non-tribal community or a community that is close to an urban population? So to say that something was a problem and throwing money at it without properly assessing and defining and getting that community feedback and collaboration with community partners, then you're just kind of like, you're not going to get a true picture of what issues are. And I think that whenever we talk about billing for Medicaid or even community health services, for the work that CHRs do in tribal communities, home visiting, whatever, auxiliary services for special education, the first question that I ask is, do we have the population? Do we know that it's an extensive problem? And how is this going to build capacity within a community? So I think taking that not so much the 10,000 feet view of the community, but an on-the-ground view of the community, and doing some really strong assessing is really important for you to determine whether something is going to be a revenue-based opportunity that's going to help grow a program.
Thank you. And then we just had a comment from Monica who stated, we also need to be cautious about overgeneralizing all American Indians in New Mexico.
Very true.
Okay, and I will put one more call out to see if anybody has any other questions or comments that they would like to share. Okay, so I will say thank you, Dr. Riley, for your time today and for your expertise, and we appreciate all of your efforts towards helping us create an equitable New Mexico. And thank you to all of you for joining us today. We look forward to seeing you back next week as Maria Perez from Democracy in Action presents Democracy and Health Equity. Have a great afternoon, everyone.